Hello, everyone. My name is Frank van Haren. First, I'd like to thank the organizers to invite me to give this talk on this virtual conference. I'll be talking about nebulized heparin as a treatment for COVID-19. I have no relevant disclosures for this presentation, except perhaps that I'm currently in quarantine, as you may be able to see because of my background, in a very small room on an island in the middle of the Pacific. The island is called Nauru. And once I get out of quarantine next week, I'll be helping with the intensive care support and response to the COVID crisis. So, as you're all aware, COVID has spread globally, and by the time you hear and see this talk, these numbers will be outdated. But at the moment, there are almost 20 million confirmed cases in the world and about 750,000 deaths. As you also know, COVID-19 causes a whole spectrum of diseases. This was a study from the Chinese CDC, 72,000 cases of confirmed or suspected COVID-19. And as you can see, in the majority of cases, it is mild, 81%. Severe cases with dyspnea and hypoxia are seen in 14%, and only 5% gets critical disease, needing respiratory support, ICU. From the confirmed and suspected cases, the fatality rate has been reported in this case series as 2.3%. Now, up to a quarter of patients who are admitted to hospital for COVID-19 require mechanical ventilation. They get COVID-19 associated ARDS. The mortality of that has been reported as quite high, over 60%, which is higher than ARDS hospital mortality as we know it, which is around 40%. Indeed, there's also a high incidence of thrombotic complications and pulmonary embolisms. And because of this combination of severe hypoxia and relatively well-preserved lung mechanics, it was postulated that COVID-19 perhaps causes a new type of ARDS or a new phenotype of ARDS. Very recently, we have shown that this is not the case, and this is now will be published shortly in the Blue Journal. We went back to the LungSafe study, which was a large global study of ARDS around the world. And in over 1,000 patients where we had controlled ventilation data and compliance data with ARDS, we found that 3/4 of patients have a low compliance with hypoxia. They would be called phenotype H in this new proposed phenotype distribution. H stands for high elastance, which is low compliance. But in LungSafe, we also found that 1 in 8 patients have a very high or normal compliance, over 50. They would be called phenotype L in this new proposed nomenclature. So essentially, 1 in 4 patients in LungSafe had a compliance over 40, and 1 in 8 had a compliance over 50, which basically shows that this high compliance with severe hypoxia is nothing new, and we saw that in pre-COVID ARDS in LungSafe already. This is another graph from that paper that shows the distribution of compliance and PF ratio. And as you can see, across the entire range of PF ratio severity of ARDS, there's a huge heterogeneity of compliances possible. So back to nebulized heparin. How does it work? Why does it work? Well, first we need to briefly talk about the pathophysiology of COVID-19 ARDS or COVID-19 pneumonia. And the first step, of course, is that when SARS-CoV-2 enters the lungs, it needs to enter the cell, and it does that by binding to angiotensin converting enzyme 2 via the spike 1 receptor protein. It then gets into the cell, and by hijacking that receptor, there is an abundance of angiotensin II, which then leads to vasoconstriction and lung injury via the type 1 angiotensin receptor. Now, these ACE2 receptors are, on lots of different cells, but mainly on epithelial cells type 2, but also on endothelial cells. So this is how the virus gets into the cell. The next and very important part of the COVID-19 pathophysiology has to do with coagulation. Coagulation is usually abnormal, and fibrin contributes to both hyaline membrane formation in the alveoli, contributing to the diffuse alveolar damage that we see, as well as to microthrombosis, inflammatory thrombus formation in the blood vessels in the lungs. So this is an important part. And that's been reported in many case series now, including this large prospective cohort study where COVID ARDS was compared to non-COVID ARDS, and COVID ARDS had significantly more coagulopathy, thrombosis, and PE. In this histological study from Sao Paulo in Brazil, where they did minimally invasive autopsy, ultrasound guided, you can see in the left upper panel, panel A, that there is definitely diffuse alveolar damage in the lungs caused by COVID-19. In the other three panels, B, C, and D, you can see thrombi in the small vessels in the lungs, both in healthy parts of the lungs and in diseased parts of the lungs. The next step, or not the next step, it all happens at the same time, of course, but another part of the pathophysiology is the hyperinflammation, also called sometimes the cytokine storm, that is activated by SARS-CoV-2. The macrophages become activated. They start releasing lots of pro-inflammatory mediators, causing inflammation, as well as neutrophils entering the alveoli, starting to be activated. And as a consequence of that, we'll see what's called NETs, or neutrophil extracellular traps, that cause further lung damage. So where does heparin come in there? How does heparin work? Well, first of all, remember, the virus needs to enter the cell via that ACE2 receptor. Well, heparin actually blocks that from happening. So unfractionated heparin binds to the spike protein receptor binding domain of the virus and blocks it. It causes a conformational change and blocks it from entering the cell. So heparin is essentially an antiviral treatment which can stop the virus from entering the cell. This could have huge implications also for public health if we were to test this and use this to stop the virus from spreading in patients who are infected, even in a home situation or in a healthcare situation. This has a huge potential which currently is untested. That heparin inhibits the virus from entering the cell was nicely shown in this study from Julia Tree and co-workers from the UK, from Public Health England, where they showed that unfractionated heparin at a concentration that is similar to what we would have in our body when we use it as a treatment, causes quite significant inhibition of the virus from entering the cells. That inhibition is about 100 times stronger than it is for low molecular weight heparins, such as clexane on the right-hand side. The next action of heparin is obviously the anticoagulation, which helps limit hyaline membrane formation and helps limit thrombus formation in the blood vessels. Heparin is also a very strong anti-inflammatory drug, and it will stop the macrophages from releasing all these inflammatory mediators, and it will also actually directly reduce these neutrophil extracellular traps. Finally, I didn't talk about this, but about 1 in 3 or 1 in 4 patients get a lot of mucus production in COVID-19. Nebulized heparin is an effective mucolytic, agent, and as such has been used for many, many years for diseases such as cystic fibrosis, with a good safety profile and good effectivity. So we all summarized this in this paper that came out a few weeks ago in Critical Care. And in this paper, we also summarized the actual evidence that it improves lung injury. So first of all, there's a whole list of animal studies, preclinical evidence that all show that nebulized heparin in these animal models of lung injury reduced pulmonary coagulation, reduced inflammation, and improve oxygenation. There's also a lot of clinical evidence. In a lot of studies that looked at acute lung injury, burn studies, other studies, nebulized heparin, again, reduced the coagulation in the lungs, it reduced dead space, it reduced some of the lung injury scores, and it increased days free of mechanical ventilation. The most important study to date is this study, which will be published very soon, hopefully before you actually get to watch this presentation. This is a phase 3 study, double-blind, placebo-controlled in 256 patients. These patients had ARDS or were at risk of ARDS. This is before COVID. But this study, quite importantly, revealed that inhaled heparin attenuates lung injury. It reduces the number of patients that had developed new ARDS. It reduced the lung injury score, and we saw a faster recovery with more survivors going home at day 60. So that's a very important study. The study was run by this gentleman here, Dr. Barry Dixon from Melbourne. He's the brain behind all this, and also launched the COVID-19 study looking at the effect of nebulized heparin in COVID-19. At the moment, we're combining studies around the world in a so-called meta-trial with nebulized heparin, looking at nebulized heparin in mechanically ventilated patients with COVID-19. So we have Australia, Ireland, the UK, Spain, and the US, more countries to follow hopefully soon. That's the dose, and we compare this with standard care and look at clinically relevant patient outcomes. The other very important initiative at the moment is the ACCORD-2 study, which is a large platform trial in the UK, where investigators look at the safety and efficacy of nebulized heparin in COVID-19 patients in hospital. So this is pre-ICU. This is to try and keep them out of ICU, a very important study recruiting right now. So in summary and in conclusion, there is a very strong biological rationale to test this intervention, nebulized heparin, as a treatment for COVID-19. It's an antiviral drug. We knew this already because heparin also prevents binding from many other viruses, RS virus, the previous SARS. Obviously, heparin has anticoagulant effects, which is important in this particular COVID-19 disease that causes a lot of clots, anti-inflammatory and mucolytic. There's a strong clinical rationale. It's safe, we know that. And we know from previous studies, especially this large randomized controlled study, that it improves lung injury and ARDS. And finally, it could have quite important public health implications if we were to test this. So I invite everyone who listens to think how we could perhaps test this in the public domain in terms of reducing the spread of infection by nebulizing heparin. And certainly, anecdotally, there have been healthcare workers who now use nebulized heparin themselves before and after doing aerosol generating procedures on their COVID-19 patients in intensive care. So thanks very much for listening. Again, this is all summarized in this paper that you can find in Critical Care. If anyone would like to join this meta-trial, this international meta-trial, please email me. The email is right at the bottom there. Or if you have any questions or comments, just shoot me an email. I'd be happy to respond. Thank you very much.